Welcome back to my channel, Pattern of Good Works. My name is Donna, and today we will be in the book that is entitled The Specialty Practice of Rehabilitation Nursing, a Core Curriculum, the 8th edition. We will start out on page 192, and we're reviewing bowel and bladder care. So on our recent video, we talked about activities of daily living. In this week, we are starting out on page 192, and it says, bowel and bladder continence is a fundamental element of functional independence. Toileting is a recurring activity of daily living, and the ability to independently toilet reflects every element measured by the functional independence assessment. So I want to hone in on the word continence. Merriam-Webster says that continence is the ability to retain a bodily discharge voluntarily. In order, according to page 192 and 193, to have continence, you're going to have an interplay of the urinary, gastrointestinal, and neurological systems, as well as functional skills. And the functional skills would be judgment and the physical capability by an individual. So we're going to look at this, and this is what the registered nurse or the CRRN is going to also do. This is one of their skill sets, and it's a part of ADPI. And let's plug ADPI. ADPI means assessment. The D stands for diagnose. The P stands for plan, implement, and evaluate. So the nurse is going to need the assessment piece first. So the nurse on admission is going to perform an assessment, and the nurse must critically assess each client, which includes obtaining a thorough medical history in order to identify symptoms of bowel or bladder dysfunction. It says that the nurse should, in their initial assessment upon admission, do an assessment. And then there's another assessment, the routine shift by shift based assessment, and then continuously evaluate the effects of any therapeutic intervention. One thing the nurse is also going to do is look at the individual continence patterns, and those should be regularly examined so that care planning can be continuously adjusted as the clients work toward achieving continence. So still looking through the lens of ADPI, we talked about assessment. Now we're going to talk about D for diagnosis. So the patient will have a medical diagnosis from the medical staff, but we also want to include a nursing diagnosis. And NANDA International Inc. still provides us with nursing diagnosis. And what does a nursing diagnosis do? It really provides a structured framework and an individualized care plan that will help us to treat whether it be the psychosocial needs or the physical needs of the patient. For example, urge urinary incontinence as a nursing diagnosis will help us to plan our treatment plan for this particular patient. So now we're going to look at the P. The P stands for the planning phase, and the nurse will develop a plan of interventions to educate the patient on strategies for maintaining continence during the inpatient stay and to prepare the patient and or caregiver for effective self-management where? In the community. You will need the assistance of the entire interprofessional team to get this done. And who are the people in your neighborhood? Who are the people on the interprofessional team? These members can include, of course, the APN, advanced practice nurse, the physical therapist, the occupational therapist. We also see the social worker, the pharmacist, the dietitian, and unlicensed assisted personnel, better known as UAPs. And of course, we're going to have physicians. And the whole thing is to get very specific on the interventions that are going to be used to achieve continence. And how are we going to do this? The members together are going to specifically focus on learning with, from, and about each other to really optimize the care delivery. And this is really done between shift to shift assessments and collaboration to maintain continuity of caregiving practices and really to coordinate care and also to track the care. It's necessary that The nurse and the nurses share information, PT, OT, everyone is sharing information with each other. And the teaching of the family is very important as well, because many clients going home will go home at varying degrees. So ensuring that there's a home visit by the PT or OT before the patient goes home is also very helpful. We want to get as close to normal bowel and bladder function to really start with. And the GI system is really important. So the GI tract, as you know, starts where? At the mouth and ends at the anus. And the system is divided into functional structures separated by sphincters that control movements of gastric contents through the GI tract. And we're on page 193. Peristalsis acts in conjunction with the physiochemicals of the epithelial cells along the tube of the GI tract to digest and absorb nutrients from foods consumed. Once the GI contents have reached the latter half of the colon, the residual unabsorbed content of previously digested food is eliminated from the body as waste through the process of defecation. Before I forget, there are 3 things to remember about the planning phase. 1, be sure to use evidence-based practices or research. 2, be sure that you teach the patient and or caregiver the why behind your action. And 3, be sure to use measurable, outcome-based driven goals. On page 194, the stomach is a muscular pouch whose function is to churn and squeeze swallowed food, while gastric glands deep in the rugae secrete hydrochloric acid to facilitate digestion. Gastritis, which is inflamed gastric mucosa, can happen due to spicy foods, acidic foods, NSAIDs taken on an empty stomach, stress, which can be physiological and or psychological, respiratory and or renal failure. And the normal bowel elimination can be attributed to a healthy gut flora or microbiome of bacteria. Gut flora can be disrupted by oral or intravenous antibiotics. So we now look at in the ADPI implementation. So we want to carry out any activities or interventions outlined by the plan of care. We then want to evaluate. And how do we evaluate? We're going to assess the client's progress and determine whether the plan of care was effective. And the initial plan may be revised if the goal was not achieved. So now we're going to look at Bristol Stool Scale. And the Bristol Stool Scale is really an assessment tool for assessing function. And it was created by 2 British researchers in 1997. And this chart really provides a guide to evaluate both hydration and transit time of GI contents through the intestines. The rehabilitation nurse can use it as an educational tool when discussing normal bowel patterns and setting goals for bowel management. And that's how we can really evaluate whether or not the patient is doing well, whether or not they have enough fluid balance. And remember that the Bristol stool chart goes from type 1 all the way to type 7. And it looks at severe constipation all the way through mild constipation, normal, a lacking of fiber, a mild diarrhea to severe diarrhea. Remembering on page 195 that it says normal defecation. On average, the human body evacuates at approximately the same time and about the same amount each day. Defecation is the result of the parasympathetic and sympathetic nerves controlling the anal sphincters. The functional ability to safely approach and get up from a toilet and the ability to self-manage clothing and perform personal hygiene are components of healthy defecation. In addition, personal habits, preferences for privacy, and availability of adequate toileting facilities are required for normal and easy defecation. The process and patterns of normal defecation have cultural influences as well. So remember to take that into consideration, actually. Nurses being culturally competent, and we know who that theorist is, I'm not going to say it, is really necessary because everyone doesn't go at the same time. Every nationality or ethnicity may do things very differently. I'm going to just read this from the book on page 195, which really talks about the neurophysiology of the bowel system. It says the ENS is a semi-independent autonomic nervous system of the gut. It is constantly activating the gastric tissues to squeeze and propel GI contents forward. It says the four primary nerves involved in the autonomic stimulation of the colon and rectum are the vagus nerve, which is the 10th cranial nerve, and branching nerves from the inferior mesenteric ganglion, which is T10 to T12 spinal cord segment. Hypogastric nerve L1 to L2 spinal cord segment, and pelvic nerve plexus S1 to S2 spinal cord segment. Now, the voluntary control of keeping the rectal sphincter closed, providing fecal continence by somatic stimulation, occurs via the pudendal nerve, which is S2 to S4 segment. So this week in review, we had an opportunity to look at bowel and bladder care in chapter 11. We talked about the interprofessional team that helps each other to ensure that the patient gets the necessary treatment to become as independent as they can be. We looked also at the Bristol stool chart. And lastly, we talked about nerve innovation. I want to thank you for coming along on this journey. I'm going to ask that you like, comment, and subscribe. Share this information with a friend. I'm wishing you all the best. Take care. Bye-bye.